Good afternoon. My name is Marco Castori. I am a clinical geneticist working in Italy, in Puglia more specifically, at the research hospital Casa Sollievo della Sofferenza. In this presentation, I will illustrate you the approach that I use in children with joint hypermobility in order to assess joint hypermobility and evaluate its relevance concerning the clinical suspicion. I generally see children with joint hypermobility with the suspicion, obviously, of Ehlers-Danlos syndrome or other connective tissue disorders. But joint hypermobility is quite common in the general population, especially in children. So a few general concepts are useful for the clinical practice, also for rheumatologists and other specialists that manage musculoskeletal issues. This is the outline of this presentation. I will focus on 7 aspects aimed at guiding the audience into the definition of joint hypermobility, its impact in terms of normal variability and disease in children, the clinical differential diagnosis and laboratory approach to children, a more general laboratory approach to children with joint hypermobility. I also dedicated a few slides to specific phenotypes, namely hypermobility and hypermobility spectrum disorders, and some management fields. The last part of the presentation will be dedicated to some mental exercise around the current concept of spectrum disorder in order to put it in the best light. Joint hypermobility. Joint hypermobility is the term used to define the ability to move a joint or a group of joints beyond normality. Joint hypermobility is common in humans and its prevalence varies among populations. It is also influenced by sex and age, by occurring more commonly in females and children. This portrait allows us to recognize joint hypermobility as a physical trait or a sign rather than a diagnosis, a clinical diagnosis, and to hypothesize a complex etiopathogenesis rather than a simple Mendelian etiology. Accordingly, many epidemiological papers demonstrated the high rate of joint hypermobility in many countries and populations, nearly always showing the highest values in females and children. Since 2017, 4 major patterns of joint hypermobility are recognized. Localized joint hypermobility is limited to a single joint or a group of joints. It is common and often clinically not relevant. On the other hand, generalized joint hypermobility is diffuse, involving both sides of the body and both the appendicular and axial joints. It is characterized by a positive Baton score. 2 additional variants of joint hypermobility are recognized: peripheral and historical. Peripheral joint hypermobility is probably a variant of generalized joint hypermobility observed on hands and feet only. This means that in peripheral joint hypermobility, the Baton score is negative, but a congenital origin is presumed. Finally, historical joint hypermobility is a form of generalized joint hypermobility not yet visible at the time of examination. Joints are not hypermobile, but the patient refers to have been double jointed in the past. Joint hypermobility, or perhaps the subclass of clinically relevant joint hypermobility, is closely related to joint instability. Joint instability is a detrimental variant of joint hypermobility, or it can be considered a detrimental variant of joint hypermobility with more severe biomechanical characteristics. On this perspective, joint instability can be considered a pre-pathological condition, bridging the gap between joint hypermobility, that is a neutral term, and joint macro and repetitive micro traumas, which led to symptoms, musculoskeletal symptoms. Nevertheless, joint hypermobility is observed not only in combination of ligamentous laxity, but also of a series of different categories of disorders or anomalies comprising muscle, neurological, and bone disorders. In a broad sense, joint instability may be perhaps considered an endophenotype for recurrent dislocations and chronic joint pain. Joint hypermobility may be described as a common multifactorial trait with a neutral value in terms of clinical significance. However, a list of musculoskeletal symptoms and signs seem to associate not casually with joint hypermobility. They include dislocations, soft tissues, traumas, arthralgias, muscle weakness and hypotonia, minor muscle weakness and hypotonia, lack of proprioception or clumsiness, mild to moderate reduction of the bone mass, and minor skeletal traits, such as a mild scoliosis, flat feet, genu valga. The association with precocious osteoarthritis is likely, but evidence remains contrasting at the moment. And together with being a physical trait contributing to human variability and a predisposing factor to a series of musculoskeletal features, joint hypermobility is also a sign for a growing number of genetic disorders. The occurrence of joint hypermobility in syndromology is wide, but not unspecific. In fact, joint hypermobility presents with moderate to high penetrance in specific subsets of genetic disorders, mainly hereditary connective tissue disorders. Generalizations around joint hypermobility allow us to identify three main roles for this physical sign in human health and disease. The degree of distribution over the body of joint hypermobility defines the types according to its extension. Joint hypermobility is also a predisposing factor, or can be considered a predisposing factor for musculoskeletal system, and as well as a neutral body sign apparently increasing the risk for specific extra musculoskeletal comorbidities. I will dedicate a few slides to this topic later. Finally, joint hypermobility, and particularly generalized and peripheral joint hypermobility, may be a sign for various monogenic syndromes. Children with joint hypermobility. Finding a single hypermobile joint in a child is extremely common, if not a rule. Therefore, attributing clinical significance to a single hypermobile joint in a developing human is risky, especially if this finding is not contextualized. In summary, a very little emphasis should be attributed to a single hypermobile joint in children. Also, the finding of two or a few hypermobile joints is common in children. Nevertheless, peripheral joint hypermobility or borderline Baton score values should not be discarded in all cases. Contextualization by review of system and family history is required. Okay. In children, a Baton score that equals or overtakes 6 stands for double jointedness, a feature that could be considered congenital and therefore of potential genetic origin. Nevertheless, congenital is not a synonym of genetic, and genetic is not a synonym for syndromic. Therefore, not all children with a positive Baton score have a detectable mutation and are affected by a true genetic syndrome. Familial aggregation is observed in both syndromic and non-syndromic joint hypermobility, but also in both symptomatic and asymptomatic or benign joint hypermobility. Now a few slides of the differential diagnosis in children for joint hypermobility. Assessing double-jointed children should always consider the intricate intersections between age at examination and the most likely diagnosis. Noting joint hypermobility in children is rarely a solitary observation. Usually, parents and physicians are aware of joint hypermobility if the baby presents something else. The spectrum of conditions presenting joint hypermobility in childhood is extremely wide and ranges from early onset, often lethal conditions, such as selected congenital muscular dystrophies, to chronic and often unspecific phenotypes featuring chronic symptoms, such as the hypermobility spectrum disorders. The contribution of joint hypermobility to the overall phenotype depends on such a variability, and is minimal in early onset severe disorders to critical in a specific phenotypes or dominant in a specific phenotypes. As clinically relevant joint hypermobility only rarely presents in isolation, the pattern of associated signs and symptoms is determinant for orienting the following differential diagnosis. There is a set of rough additional major signs that easily suggest to the physician the category of disorders in which the patient likely falls. These categories mainly include congenital muscle disorders, skeletal dysplasias, genomic and other multiple malformation syndromes, and hereditary soft connective tissue disorders. Among the various disorders comprised within the category of hereditary soft connective tissue disorders, we have a relatively limited, although phenotypically variable number of disorders that need to be considered and suspected on the basis of the pattern of additional signs. Finally, in the absence of major signs, some minor anomalies might help in formulating the suspicion and therefore guiding a molecular test. Absence of one or more major signs reduces but not exclude the presence of a monogenic disorder. In this case, and usually an hereditary connective tissue disorder. In this case, an attenuated form of hereditary soft connective tissue disorder remains the most likely unexpected syndromic diagnosis, especially in the absence of global developmental delay. Series of minor anomalies might help in supporting the hypothesis, but prudence is needed in considering the significance of some of them, such as soft and velvety skin and blue sclera, especially in neonates and toddlers. Here I tried to summarize the major additional features for joint hypermobility by considering the main fields for the differential diagnosis. The 6 main phenotypic categories presenting joint hypermobility as a clinically relevant physical attribute include a specific musculoskeletal phenotypes, again, to which I will dedicate a separate section in this presentation, disorders with predominant skin involvement, comprising some rare subtypes of EDS and hereditary cutis laxa, disorders with predominant skeletal involvement, such as skeletal dysplasias and some rare subtypes of EDS, disorders with predominant cardiovascular involvement, including vascular EDS, and disorders of the TGF-beta pathway, hereditary neuromuscular disorders, and pleiotropic conditions featuring neurodevelopmental disorders. Laboratory diagnostics in children with joint hypermobility. Okay, on a clinical laboratory perspective, a key issue is discriminating between phenotypes that are eligible to molecular confirmation and those for which molecular testing is not yet available. Monogenic phenotypes are those for which joint hypermobility may be considered one of the various pleiotropic manifestations of a musculoskeletal developmental disorder, an ancillary feature of a congenital neuromuscular disorder, or one of the various primary features of a monogenic connective tissue disorder. Among the phenotypes for which molecular testing is not useful, there are the hypermobile EDS, the hypermobility spectrum disorders, as well as possible combinations of common functional disorders known to non-causally associate with joint hypermobility, at least in the absence of some doubts concerning the differential diagnosis, obviously. In these cases, molecular testing can be considered for excluding monogenic forms of joint hypermobility. Another key issue for the clinical laboratory perspective is the phenotypic and molecular overlap between the various categories of monogenic disorders featuring joint hypermobility. For example, the Ehlers-Danlos syndromes represent a bridge category of disorders mixing together features of the other partially overlapping conditions. For this reason, the construction of the virtual and real multigene panels used for molecular investigations in individual joint hypermobility should consider a morbid approach to gene selection. in my opinion. In the suspicion of an hereditary soft connective tissue disorder, the first-tier analysis is currently next-generation sequencing, aimed at verifying the presence of candidate variants in all genes of interest at the same time. At present, next-generation diagnosis is carried out by applying short-read technology to multi-gene panels or exomes, at least in most laboratories. The choice between multi-gene panel and exome is influenced by a series of technological, technical, and clinical factors, such as the specificity of the suspicion, coverage issues, accuracy of copy number variation screening, the risk of secondary findings, costs, and storage issues that might vary from a laboratory to the other. In case such an approach fails to identify a causative genotype, current advances in molecular diagnostics suggest that in the near future, multi-omics approaches will substitute or integrate standard multi-gene panel and exome sequencing. Such innovative approaches, presumably consisting in the simultaneous application of DNA, mRNA, and methylome analysis, will increase the diagnosis accuracy of genetic testing by improving the clinical interpretation of splicing variants and by detecting a wide range of sequence variations that run undetected by standard short-read next-generation sequencing. This is, more specifically, this is our current laboratory and bioinformatics pipeline in the molecular diagnosis of children with a suspicion of monogenic disorder with joint hypermobility. In addition, we are working on the improvement of the detection of low-level hemosisis in sporadic cases by introducing pipelines currently used in molecular oncology. From this perspective, molecular testing on skin biopsies or samples from other more likely affected tissues could be considered in sporadic cases in order to exclude more efficiently genetic mosaicism, especially obviously in sporadic cases. Specific phenotypes. Once molecular testing has been carried out and gave negative or inconsistent results, or has not been considered appropriate, clinically relevant joint hypermobility usually rises in the context of aspecific phenotypes. Currently, aspecific phenotypes include hypermobility EDS, hypermobility spectrum disorders, and perhaps asymptomatic in musculoskeletal terms, and non-syndromic joint hypermobility with one or more comorbidities. In children, while the identification of a causative variant in gene associated with one of the pleiotropic monogenic disorder featuring joint hypermobility corresponds to a diagnosis of a chronic disorder, this is not always the case for specific phenotypes. In fact, at the moment, we do not have any reliable element or marker able to accurately predict the evolution of the phenotype in the following months and years. Such an unpredictability is only 50% source of despair, because this uncertainty on the evolution of the phenotype allows to hope for a resolution. In fact, it is really difficult to predict the destiny of a child with symptomatic joint hypermobility, and therefore to distinguish among resolution, attenuation, chronification, and transition to hypermobility EDS in adulthood. Okay. The evolution of the clinical picture cannot be accurately predicted in children with a specific phenotypes. Again, nevertheless, there are some characteristics, historical elements, and actions or activities that seem to influence phenotype evolution in the developmental age. Some of them are intrinsic and therefore untreatable, such as sex and feminine history. Others are extrinsic and consequently treatable by practices that attenuate or eradicate the detrimental factor. Among them, there are inadequate coping strategies, wrong therapies and interventions, traumas, wrong sports, and diets. Current research still offers only a fragmented picture of the far-reaching biomechanical and neuromediated consequences of joint hypermobility on the musculoskeletal and neuromuscular systems. Such a gap of knowledge explains, for example, our hesitations on predicting the evolution of symptoms in people with symptomatic joint hypermobility. However, some concepts are relatively consolidated and can be used to put together a sequence of events. Currently, joint hypermobility often couples with lack of proprioception and reduced muscle tone in people seeking medical attention due to manifestations related to joint hypermobility. Such a coexistence and mutual amplification facilitate the occurrence of some variations from the norm, comprising joint instability and a delay in motor and coordination development. In some individuals, the degree of such a variation from the norm overcomes normality and becomes clinically relevant. This is a simplified structure of the presumed natural history of symptom development, transformation, and chronification in people with generalized joint hypermobility. Musculoskeletal events characterize the so-called symptomatic joint hypermobility, alternatively called hypermobility S or hypermobility spectrum disorders. At this point, the distinction between these two disorders is based on the presence or absence of the 2017 criteria for the hypermobile ADS. People with asymptomatic and symptomatic joint hypermobility might simultaneously develop additional non-musculoskeletal symptoms related to comorbid dysfunctions of the cardiovascular and evacuatory systems, as well as the neuromotor functions. Chronification of pain is something that happens in selected cases. The precise mechanism is unknown, but a number of likely factors seem to contribute. And for this, you can find a few well-detailed reviews in the recent literature. Among them, there are treatable and not treatable factors. Their existence and role are relevant for counseling. A few slides on management issues. The mechanism leading to joint hypermobility the mechanism leading from joint hypermobility to its biomechanical and neuromediated attributes may be used to imagine a physiopathological process able to explain symptom onset, chronification, and contribution to disability. At the same time, the delineated vicious circle might be considered a plot outline for planning types and timing of intervention. From right to the left, you can see the application of physical therapy in at least two phases of this process. Behavioral therapy and psychotherapy drugs can be used in more severe or complex pain phenotypes, and physical and surgery is can be considered only in a few cases in which orthopedic surgery might help in stabilizing joints. Accepting the multidimensional nature of joint hypermobility is in constant with the Occam's razor that reads out pluralitas non exponenda sine necessitate ponenda. Nevertheless, any simple concept did not resolve entirely the conundrum of joint hypermobility as a clinically relevant scenario. Unfortunately, concepts that suggest pleiotropy, joint instability, and the ubiquitous nature of connective tissues seem numbers rather than formulas. Accordingly, a wider perspective is needed also for the treatment of joint hypermobility. Concerning the musculoskeletal system shape and perhaps symptoms should not guide the choice. Function in a developing system should represent the mainstay for choosing the most adequate approach. This perspective, my patients and their family, I usually, especially if the musculoskeletal and neuromuscular manifestations are not fallen into a vicious circle of pain, inactivity, pain, and consequently falls and risk of falls, I usually give homeworks for life. Whenever they will lie, whatever life they will have, they must remind that 90% of their quality of life will depend on their choices. Therefore, together with practical and medically oriented recommendations, there are pillars to consider for the construction of their own lives. Concepts like self-exploration, resilience, and self-management must take part in the internal life of individuals with asymptomatic joint hypermobility as the best resources that current medicine can offer. And the yin and the yang of symptomatic joint hypermobility implies that bad habits and wrong choices are patients' contributors to worsening of quality of life when they feel good. Conversely, recognizing that the wind of change comes from inside is the most effective way for improving quality of life when patients feel bad and hopeless. And finally, I dedicated some slides to some reasoning concerning what are hypermobility spectrum disorders and perhaps the hypermobile Ehlers-Danlos syndrome in medicine. I started on the definition of phenotype. There are some famous definitions of phenotype in medicine. The term phenotype is usually taken to mean some deviation from normal morphology, physiology, and behavior. This is consequently the concept of phenotype is strictly related to what we recognize as the boundary separating normality from abnormality. In the absence of a major gene, as it happens in hypermobile ADS and hypermobility spectrum disorders, a series of facts characterize the routine clinical activity. Molecular testing cannot be used for diagnosing establishment, and therefore the diagnosis is based on a combination of historical, physical, and instrumental findings. Indeterminate or incomplete diagnoses are relatively common and generally lay on the inadequacy of proposed diagnostic criteria. For this reason, diagnostic criteria are under continuous revision, as it is happening for the hypermobility ADS. That is, in fact, its criteria are currently under revision by at least two working groups in the Ehlers-Danlos Society. For this reason, diagnostic criteria, non-Mendelian familial aggregation and disease frequency variations according to sex, lifestyle, and ethnicity are common in disorders without a major disease gene. And this, for example, might explain the predominance of females in people with a clinical diagnosis of hypermobile Ehlers-Danlos syndrome, but also with hypermobility spectrum disorders. In Mendelian disorders, the separation between health and disease is usually established by a single test, which identifies or does not a mutation. This cannot occur for non-Mendelian disorders. In non-Mendelian disorders, separation between health and disease is usually identified by arbitrary cutoffs of dosages or sets of criteria. Nevertheless, the distinction between normal and abnormal variability is not always straightforward, because dosage levels may be borderline or vary in time, and clinical and criteria may be difficult to assess on or their number might fall in a gray zone. Therefore, a joint hypermobility is assumed to be a dichotomous trait in the office. This is our perception as clinicians, that joint hypermobility is present or absent in this joint, that generalized joint hypermobility is present or absent in this patient. Nevertheless, joint hypermobility is a label that we attribute with an idea of what is normal in our mind. This is also the case of double jointedness, which is assessed with the application of the Bayton score. But how frequently do we hesitate in front of individuals with borderline Bayton score, or individuals with negative Bayton score, but over joint hypermobility in joints that are not counted in this score? On an intuitive perspective, joint hypermobility is at one end of a continuous spectrum of values of joint range of motion. On The other hand, there is joint hypermobility. Similarly to joint hypermobility, also joint hypermobility may be either congenital or acquired, may associate or may not with musculoskeletal symptoms and a compromised function. As testified by the systemic features included in the 2017 criteria for the hypermobile Ehlers-Danlos syndrome, joint hypermobility not casually associated with some extramusculoskeletal manifestations such as dolichostenomania, arachnodactyly, high-arched palate, and abnormal skin texture. Now, we can also know that the relationships between joint hypermobility and pain and joint hypermobility and dysautonomia are marked. Therefore, we can assume that all such physical and pathological features tend to co-occur in humans. However, all these features can be measured and therefore can be recognized as the extremes of a normal distribution of values. We perhaps do not get wrong when hypothesize that the concurrence of these features is the result of the covariation of the related quantitative traits. The existence of covariant morphological and physiological and behavioral attributes is not novel in life sciences. In evolutionary and developmental biology, the term integration is used to define the existence of sets of covariant quantitative traits among and within species. Integration may be used to study the variability among species in order to explore the evolutionary and adaptive relationships that might exist among them. Integration can be also used to investigate the non-random variability within a single species in order to assess the changes among sexes, a phenomenon called dimorphism, not dysmorphism, but dimorphism, generations or groups of individuals. Finally, the principles of integration might have an individual dimension, particularly concerning the interrelationships between morphology and function during development. The theory of integration stands on the derived concept of modularity. Modules represents set of quantitative morphological, physiological, and behavioral traits which tend to covary. In this scenario, joint hypermobility is recognized as a segment of a variability within the physical attribute called joint range of motion, which in part is assumed to have a normal distribution. The diagnostic criteria for a constitutional disorder which follows the laws of integration may be considered as specific cutoffs of the respective quantitative traits for which they derive. The study of human variability for a critical number of quantitative traits of interest could allow us to identify a set of covariant features and therefore use the identified variability model as an unbiased source for selecting new and refining current diagnostic criteria. The ego-devo approach to human constitutional disorders not following a Mendelian inheritance, for example, hypermobile ADS and hypermobility spectrum disorders, might represent an alternative approach to the study of their esopathogenesis. The integration model is not opposed to the pleiotropy of Mendelian genetics, but rather considers pleiotropy as only one of the different factors contributing to the eventual phenotype. Hence, according to the integration model, pleiotropy is not the leading force which determines alone the disease onset, as happens in contrast in truly monogenic forms of joint hypermobility, but represents the spatial temporal dimension in which the various other contributors express their role. Therefore, modularity of covariant attributes easily explains multisystemic manifestations, variable expressivity, and non-Mendelian familiar aggregation in the absence of a major gene. I forgot the sex bias that is typical of hypermobility spectrum disorders. At the same time, integration might coexist with vandalism and explain the non-casual superimposition of common comorbidities to poorly pleiotropic manifestations directly related to mutations in single highly penetrant genes, such as chronic pain on cardiovascular dysautonomia that we can observe in people with classical Ehlers-Danlos syndrome. This easily fits with the duality of the nosology of Ehlers-Danlos syndromes and the superimposed concept of spectrum disorders. Thank you very much. Okay. There are any questions? I don't know if one question is, what is the role of parents and caregivers in joint hypermobility syndromes? What is the role, sorry, what is the role of parents and caregivers in joint hypermobility syndrome? The role is quite complicated and complex because it's, in my opinion, it's mainly depends on the severity of the symptoms that the child presents at the time of the diagnosis. In my opinion, optimism should be the first characteristic of parents and caregivers, because especially in the developmental age, the phenotype might resolve spontaneously in the ensuing years. Another issue is the life limitations that sometimes I can observe in families in which a child is diagnosed with some form of symptomatic joint hypermobility. This is not sometimes protection is a good choice, especially in children that are predisposed to dislocations. And I'm thinking especially to sports selection, for example, identifying that the right sport for the affected child. But in other circumstances, excessive protection limits excessively the lifestyle and hence the movements of the child. So another characteristic of caregivers and parents with a child with joint hypermobility syndrome should be a combination of prudence and foresight. Okay. Children suffer from pain in hands when riding at school. Any advice to treat it? Please remember that I am a clinical geneticist, so I'm not the right person for asking some practical issues. But there are a few non-specialistic proposals, such as the use of the computer at school, or the use of specific pens and pencils with that reduce the pain during writing for children. Thank you too. Thank you. No, no more questions. Thank you. There are any other questions? Okay. Diana, can we close?
Yes, in case there is no other question, I don't know if you have already encouraged to ask for questions. In case, you can still write it, maybe a couple of seconds to write it in the chat or raise your hand. Otherwise, we can close. Yes. There it is. They just need a little bit of encouragement.
Okay. What about sports? I understood it is better not limit them, but it is quite worrying to see many dislocation. Yes. Again, please. Again, I am a poor clinical geneticist, so I am not a physical therapist or a specialist in physical medicine. But in my experience, sport should not be limited. History of dislocation in specific joints might guide more tailored choice for sports selection. I think that is a general suggestion for this point.